students, in this lecture we will discuss about skin pathologies, and first we will discuss a little bit about anatomy of the skin. And you know that our skin contains epidermis, dermis, hypodermis, appendixes of the skin, stratum basale, stratum spinosum, stratum granulosum, stratum lucidum, stratum corneum. And the skin is an organ that forms a protective barrier against germs and other organisms, and keeps the inside of your body inside your body, and keeps what's outside of your body outside. Skin also helps maintain a constant body temperature. Human skin is only about 0.07 inches 2 millimeter thick. Skin is made up of two layers that cover a third fatty layer. The outer layer is called the epidermis. It is a tough protective layer that contains melanin, which protects against the rays of the sun and gives the skin its color. The second layer, located under the epidermis, is called the dermis. It contains nerve endings, sweat glands, oil glands, and hair follicles. Under these two skin layers is a fatty layer of subcutaneous tissue. The word subcutaneous means under the skin. On average, an adult has from 18 to 90 square feet, about 2 square meters of skin, which weighs about 6 pounds. That means 7 kilogram approximately. And now we will discuss about urticaria. What is urticaria? Urticaria taken from the urtica nettle and from urare to burn. Commonly referred to as hives, is a kind of skin rash notable for pale red, raised, and itchy bumps. Urticaria is a common problem. It is estimated that up to 20% of the population, or 1 in 5 people, would have had hives at one point in their lives. Urticaria is characterized by transient itchy, elevated edematous, wales, or red papules. Wale, a central swelling surrounded by erythema, itching or burning sensations. They will disappear usually within from 1 to 24 hours. Angioedema, pronounced swelling of the lower dermis and subcutes, most often found in the lips, eyelids, or genitalia, itching and sometimes pain. Resolution can take up to 72 hours. It is associated with urticaria in about 40% of cases. Classification can be ordinary urticaria acute, can be chronic and episodic. Also, physical urticaria, angioedema, contact urticaria, urticarial vasculitis. Cases, drug reactions such as can take place reactions to medications, vaccines, insulin, and other things, other medications. Drug, food additive or preservative reactions, inhaled, ingested allergens, which often come in contact with the skin. Also, maybe transfusion reactions to infections, bacterial, fungal, viral, parasitic, insect bites, stings, for example, papular urticaria, collagen vascular diseases such as systemic lupus erythematosus, cutaneous vasculitis, also can cause this disease. Serum sickness also can be hereditary. Hereditary disease also can cause. Physical triggers, heat, cold, light, pressure, and other. Causes and forms of angioedema. In this disease, immunoglobulin E is mediated allergic reactions. For example, if take foods, medications, environmental allergens, non-immunoglobulin E mediated drug induced causes, for example, ACE inhibitors, opioid analgesics, ACE and SAID induced alteration in arachidonic acid metabolic. Also can be autoimmune, idiopathic, hereditary, and acquired. In this slide, you see classification, easy classification of urticaria. Can be spontaneous, in turn spontaneous divided in acute and chronic, and also, as you see, can be physical, elicited by specific physical factors such as cold, pressure, heat, light, and other urticarial subtypes. And in turn, chronic urticaria has a peak prevalence in the middle-aged population, especially females, with a female to male ratio of 4:1. Allergic triggers acute urticaria. They are drugs, B-lactam antibiotics, sulfonamides, aspirin, foods, milk, eggs, peanuts, sesame, soy or wheat, shellfish, fish, food additives, infections, insect bites and stings, contactants and inhalants, includes animal dander and latex. Chronic urticaria, physical factors, cold, heat, dermatographic pressure, solar, and also idiopathic. In this slide you see mechanism of this disease, both enhanced vasodilatation and vasopermeability in this disease lead to plasma leakage, and histamine stimulate nerve endings, prurits, neuropeptide release, and skin response. It's easy explanation what happens in this disease in cases you see subcutaneous antigen with low dose that lead to mast cell activation, and in turn increased vascular permeability leads to localized swelling. Infections, they are viral, bacterial, parasitic, fungal. Viral, they are herpes simplex, hepatitis B, C, Cox, Sakia A and B. Upper respiratory infections, bacterial associated with certain infectious foci, dental caries, abscesses, pharyngitis, tonsillitis, otitis media, occult abscesses, and UTI. Parasitic, ascaris, strongyloids, echinococcus, toxocara, fasciola, filaria, schistosoma, and fungal candida. In this slide, you see classification of urticaria, acute and chronic. Time course, inacute less than 6 weeks, and chronic when more than 6 weeks. And causes acute immunological reactions to medications, to foods, to contact allergen, and to insect venoms, to viral infections, and maybe idiopathic. Natural history, typically self-limited, inacute, and treatment, symptom control with antihistamines. And in chronic, causes may be idiopathic, autoimmune, drug-induced, complement mediated, secondary to a systemic disorder, rarely caused by foods or other environmental triggers. Natural history, chronic with episodic exacerbations, and treatment, symptom control with antihistamines for severe refractory urticaria. Consider addition of second-line treatment such as licatriene modifiers, hydroxychloroquine, and cyclosporine. Physical urticaria. The physical urticarias are characterized by the development of peeling and itching promptly after application of the appropriate physical stimulus. Whales typically fade within 30-60 minutes. The exception is delayed pressure urticaria when the whales take several hours to appear after sustained pressure and can last up to 48 hours. Physical urticaria, subtypes, and triggering factors. Subtypes due to mechanical stress, such as dermatographism, delayed pressure urticaria, vibratory urticaria, and contact urticaria. Triggering, mechanical, scratching, rubbing, and constant pressure on skin, any vibrating force. Triggering factor, urticariogenic substance. If due to temperature change, such as cold contact urticaria or heat contact urticaria. Triggering factors are cold objects, weather, and localized heat source. If due to sweating or stress, such as cholinergic urticaria, sweating, adrenergic urticaria, exercise-induced urticaria. Triggering factors: increased core body temperature, stress, and physical exercise. If due to other causes, for example, solar urticaria and aquagenic urticaria, ultraviolet or visible light, and in aquagenic urticaria, contact with water. Physical urticaria, cholinergic or stress, itchy, monomorphic pale or pink wheals on trunk, neck, and limbs after exercise or a hot shower, spicy food, under too many covers. Anything that raises internal body temperature. Prevalence of 11% in the age group of 60 and 35 years. Physical urticaria, pressure, large, painful, or itchy red swelling at sites of pressure, if they soles, palms, or waist, lasting 24 hours or more. Application of pressure perpendicular to skin produces red swelling after a latent period of 1 to 4 hours. Dermographic urticaria, itchy liner veils with surrounding bright red flare at sites of scratching or rubbing. The most frequent form of physical urticaria, affecting mainly young adults. Mean duration 5 years. Heat, physical urticaria with heat, a rare form of urticaria induced by direct contact of the skin with warm objects or warm air. The eliciting temperature ranged from 38 Celsius to more than 50 grades of Celsius. Cold physical urticaria, itchy pale or red swelling at sites of contact with cold surfaces or fluids. 10 minutes application of an ice pack causes a wheal within 5 minutes of the removal of ice. Lukewarm water immersion of for aquagenic urticaria. Urtication in aquagenic urticaria should not be performed in patients with a history of aquagenic edema or anaphylaxis. Contact urticaria. Contact urticaria is an important manifestation of natural rubber latex allergy. Laboratory assessment, initial tests at CBC with differential, erythrocyte sedimentation rate urinalysis, possible tests for selected patients, stool examination for ova and parasites, blood chemistry profile, anti-nuclear antibody titer, hepatitis B and C, skin tests for immunoglobulin E mediated reactions, RASD for specific immunoglobulin E complement studies such as CH50, Cryoproteins. We should find cryoproteins in these patients. Thyroid microsomal antibody and anti-thyroglobulin, thyroid stimulating hormone. We can use skin tests in allergy with allergens for tests, known concentrations with known concentrations. Therapy for urticaria. Search for triggers, treat the treatable causes, and antihistamines. We can use short-acting, such as Benadryl, Atarax, and long-acting. They are Claritin, Reactin, and others. And also we can use corticosteroids. Start around 1 milligram per kilogram per day, single or divided doses. And next is psoriasis. What is psoriasis? It is inflammatory and hyperplastic disease of skin, characterized by erythema and elevated scaly plaques. Maybe chronic relapsing condition. Course of disease often unpredictable. Symptoms of psoriasis. As you see here in this slide, most frequently experienced symptoms most often is scarring, next itching, skin redness, tightness of skin, bleeding, burning sensation, fatigue, and others. And also psoriasis is very difficult disease that affects emotional state. First one, person can patients are concerned that disease would worsen, and feelings of embarrassment, feelings of unattractiveness, and also psoriasis leads most time to depression of patients. Epidemiology is common skin disorder, prevalence variable 0.3 to 5%, 2 or 5%, and prevalence equal in males and females. Estimated incidence 60 per 100,000 per year. Mean age 23 and 37 years. Current theory. Two distinct peaks with possible genetic associations: early onset and late onset. Early onset 16, 22 years, and more severe and extensive in early onset, more likely to have affected first degree family member, and late onset 57 to 60 years. Milder form affected first degree family members and nearly absent. Genetic influence. Evidence suggests strong genetic association. Studies of monozygotic twins show concordance for psoriasis. Multiple susceptibility loci have been identified. Disease expression, likely result of genetic and environmental factors. Common trigger factors for psoriasis: infections such as streptococcal, viral, and other, skin trauma, Kopner phenomenon, psychological stress, drugs, lithium beta blockers and other also can lead to psoriasis, can be as causing sunburn, metabolic factors, for example, if they calcium deficiency, hormonal factors in pregnancy, for example. Psoriasis is a T cell mediated. You know that can be B cell mediated and T cell mediated. And psoriasis is a T cell mediated autoimmune disease. Current hypothesis: unknown skin antigens stimulate immune response. Antigen specific memory T cells are primary mediators. Leads to impaired differentiation and hyperproliferation of keratinocytes. Clinical presentation: if they classic psoriasis, well defined and sharply demarcated, round oval shaped lesions, usually symmetrical, erythematous raised plaques covered by white silvery scales. Common sites affected by psoriasis can affect any part of the body, typically scalp, elbow, knees, and sacrum. Extent of disease varies. Types of psoriasis: chronic plaque, cutate, flexural, erythrodermic, postural, local forms. Chronic plaque psoriasis. Most common type affects approximately 85%. Features pink, well-defined plaques with silvery scale. Lesions may be single or numerous. Plaques may involve large areas of skin. Classically affects elbows, knees, buttocks, and scalps. You see chronic plaque psoriasis. Can be symmetrical or non-symmetrical. Next one, cutate psoriasis, numerous and small lesions, approximately 1 centimeter diameter, pink with less scale than plaque psoriasis. Commonly found on trunk and proximal limbs, typically seen in individuals 30 years. Less than 30 years, often preceded by an upper respiratory tract streptococcal infection. Flexural psoriasis, lesions in skin folds, particularly groin, gluteal cleft, axilla, and submammary regions. Often minimal or absent scaling, may cause diagnostic difficulty when genital or perianal region is affected in isolation. Erythrodermic psoriasis, generalized erythema covering entire skin surface, may evolve slowly from chronic plaque psoriasis or appear as eruptive phenomenon. Patients may become febrile, hyperthermic, and dehydrated. Complications include cardiac failure, infections, malabsorptions, and anemia. Relatively uncommon. Postural psoriasis have two forms, localized and generalized forms. Localized form, more common, presents as deep-seated lesions with multiple small pustules on palms and soles. Generalized form, uncommon, associated with fever and widespread pustules across the body, inflamed body surface. Palmoplantar psoriasis can be hyperkeratotic or postural, may mimic dermatitis. Look for psoriatic manifestations elsewhere to aid diagnosis, possibly aggravated by trauma. And scalp psoriasis varies from minor scaling with erythema to thick hyperkeratosis plaques, may extend beyond hairline. Patients scratching may produce asymmetric plaques. Nail psoriasis may be present in patients with any type of psoriasis, can take several forms. Pitting, discrete, well circumscribed depressions on nail surface. Subungual hyperkeratosis, silvery white crusting on the free edge of nail with some thickening of nail plate. Onycholysis, nail separates from nail bed at free edge. Oil drop sign, pink, red color, change on nail surface. Psoriatic arthritis. Approximately 5 to 20% have associated arthritis. 5 major patterns of psoriatic arthritis. They are distal interphalangeal involvement, symmetrical polyarthritis, psoriatic spondyloarthropathy, and arthritis mutilans, oligoarticular asymmetrical arthritis. Clinical expressions often overlap. Diagnosing psoriasis. Other dermatological disorders can resemble psoriasis. Diagnosed clinically according to appearance, distribution, history of lesions, and family history. Important to consider non-cutaneous complications. Impetigo. Impetigo is a superficial skin infection that is seen most commonly in children. The infection is generally classified as bullous or non-bullous based on clinical presentation. Impetigo is most common during hot, humid weather, which facilitates microbial colonization of the skin. Minor trauma, such as scratches or insect bites, allows entry of organisms into the superficial layers of skin, and infection ensues. Impetigo is highly communicable and readily spreads through close contact, especially among siblings and children in daycare centers and schools. Etiology: most cases of impetigo were caused by Streptococcus pyogenes, but recently Staphylococcus aureus is alone or in combination with pyogenes bacteria has emerged as the principal cause of impetigo. Staphylococcus pyogenes. Stages of impetigo by type. There are 3 types of impetigo based on the bacteria. that cause them and the source they form. Each type goes through a series of stages. First one, non-bullous impetigo, next bullous impetigo, and third, ectema. Non-bullous form. Non-bullous impetigo is mainly caused by Staphylococcus aureus. It's the most common form of impetigo. It goes through the following stages. It usually starts with reddish, itchy sores around the mouth and nose. The sores break open, leaving red and irritation skin around them. A browning yellow crust. Bullous impetigo. Bullous impetigo is almost always caused by Staphylococcus aureus bacteria. It usually forms larger blisters or bullae filled with a clear fluid that may become darker and cloudy. The blisters start on unbroken skin and are not surrounded by reddish areas. The blisters become limp and clear and then burst open. A yellowish crusty sore forms over the area where the blisters broke open. Ectema. This more serious infection is much less common. It occasionally happens when impetigo is not treated. Ectema goes deeper into the skin than the other forms of impetigo and it's more severe. The infection forms painful blisters on the skin of the buttocks, thighs, legs, ankles, and feet. The blisters turn into push-filled sores with a thicker crust. Often the skin around the sores turns red. Clinical manifestation have general exposed skin, especially the face, is the most common site for impetigo. Symptoms: pruritus is common, and scratching of the lesions may further spread infection through excoriation of the skin. Other systemic signs of infection are minimal. Weakness, fever, and diarrhea sometimes are seen with bullous impetigo. Signs: non-bullous impetigo manifest initially as small fluid-filled vesicles. These lesions rapidly develop into pus-filled blisters that rupture readily. Purulent discharge from the lesions tries to form golden yellow crusts that are characteristic of impetigo. In the bullous form of impetigo, the lesions begin as vesicles and turn into bullae containing clear yellow fluid. Bullae soon rupture, forming thin, light brown crusts. Diagnosis with laboratory tests and with using other diagnostic tests. Laboratory tests: cultures should be collected. Crusted tops of lesions should be raised so that purulent material at the base of the lesion can be cultured. Cultures should not be collected from open, draining skin pustules because they may be colonized with staphylococci and other normal skin flora. Other diagnostic tests: complete blood count is often performed because leukocytosis is common. Pathophysiology of impetigo. Bullous impetigo producing exfoliative toxin that contains serine proteases acting on desmoglein, a structurally critical peptide bond in a molecule that holds epidermal cells together. This process allows Staphylococcus aureus to spread under the stratum corneum in the space formed by the toxin, causing the epidermis to split just below the stratum granulosum. Large blisters then form in the epidermis with neutrophils large blisters then form in the epidermis with neutrophil. In bullous impetigo, the bulla rupture quickly, causing superficial erosion and a yellow crust. Non-bullous impetigo, Streptococcus typically produces a thick-walled pustule with an erythematous base. Histology of non-bullous established lesions shows a thick surface crust composed of serum and neutrophils in various stages of breakdown. With treatment, oral adult dose, dicloxacillin, dixacillin 25 to 50 to 500 milligram every 6 hours. Cephalexin 2050 every 6 hours. Cefadroxil Cefadroxil 500 milligram every 12 hours. Clindamycin 150 to 300 milligram every 6-8 hours. Mupirocin ointment every 8 hours, and oral pediatric dose as you see here. And next topic, pemphigus pemphigus vulgaris. What is it? This patient complains of this painful outbreak. You tell them they have a poor hygiene, bullous pemphigoid, and C. pemphigus vulgaris and bullous impetigo. Pemphigus vulgaris. Pemphigus vulgaris is the most common form of pemphigus. Oral lesions usually precede the skin blisters by weeks to months. 80% present with oral lesions first. The primary lesion is a flaccid blister bulle that easily ruptures and leaving erosions and the crusting and eventual marked post-inflammatory changes. In severe cases, the oral epithelium is completely denuded and is associated with intraoral pain that is particularly worsened by eating. Infrequently, other mucous membranes may be involved. ocular and genitourinary. Non-pruritic skin blisters varying in size from 1 to several centimeters gradually appear and may be localized for a considerable time. The lesions become invariably more generalized if left untreated. It is usually most accentuated in the trigenous areas. The etiology is from autoimmunity to the pemphigus vulgaris antigen is desmoglein 3, a member of the cadherin family and a normal component of human keratinocyte cell membranes. DIF reveals immunoglobulin G in the intercellular regions of the epidermis in and around the affected parts of the skin or mucous membranes. C3 immunoglobulin M and immunoglobulin A are found much less frequently. Indirect IF studies are positive and can be used as an indicator of disease activity. Monkey esophagus. The basal cells lose their intercellular bridges, but they remain attached to the dermis, giving a tombstone appearance. The blister cavity usually contains a few acantholytic cells, which often show degenerative changes. Clinical picture: skin biopsy for light microscopy, skin biopsy for direct IF studies. Indirect IF studies levels correlate with disease activity. Pemphigus vegetans. This is a variant of Pemphigus vulgaris in which markedly hyperplastic erosive plaques develop, primarily in intertriginous regions, groin and axillary vaults. At times, such lesions occur in some patients with long-standing Pemphigus vulgaris. Pemphigus vegetans is characterized by flaccid bullae that become erosions and form fungoid vegetations or papillomatous proliferations, especially in the body folds. The bullae rupture and become exuberant with varicose vegetations capped by crusts and surrounded by a zone of inflammation. Treatment of Pemphigus vulgaris is oral steroids, azathioprine, cyclosporine, plasmapheresis, and rituximab. Dear students, we finished this lecture, and I think that this lecture was useful to you. I hope so and see you next time. Goodbye. Have a nice.